Depression is one of the symptoms that is very common among the patients who are terminally ill. In this session, we will see about the details of depression, the clinical identification of depression, the diagnostic criteria that are used to identify depression, and also we would see the treatment procedures that are available to get remedy from depression. Significant symptoms of depression are reported to occur in the patients who are terminally ill. Depression has been found in about 25 to 35% of patients with advanced cancer. When they are in grade 3, grade 4 cancer, and when it is known that they may no longer survive, depression has been found in such patients to the extent of 25 to 35%. And in a similar number of patients with other life limiting illness, not only cancer, but also in other diseases where there are no chances of survival of that particular patient, depression has been found. The incidence is probably higher in patients with advancing disease, increasing disability, or troublesome pain. So, depression is very common in patients in whom the disease is progressing. It can be any kind of disease, renal disease or cancer, or it can be any kind of disease, and where there is increasing physical disability. Since the disease advances, there will be different kinds of disability in the patient. They may not be able to eat or walk or do their work. Any kind of disability may be associated as the disease progresses, and the troublesome pain. So, all the diseases, illnesses are associated with some type of pain. So, unbearable pain is there in some kinds of diseases, and this also makes the patient depressed. In palliative care, many patients with depression are not diagnosed or treated properly. So, we should understand that in the palliative care, more attention is given to the symptoms and the symptom management of the patient. And this aspect of depression is not given care particularly, and it is not even diagnosed in some patients. The diagnosis is missed. It is wrongly thought to be inevitable. So, what the volunteers or the people who takes care of the patients feel is that the depression is part of the disease. That is how they look at it. But you have to give importance to the depression that occurs in the palliative, the patients who are taking palliative care. And if it is properly treated, you can get rid of the depression from the patients, and you can make the patient overcome that depression. It is wrongly thought to be inevitable. So depression is not a integral component of any disease. It can be treated, and the patient can overcome the depression. It is regarded as unlikely to respond to antidepressants, and it is generally thought that people who are depressed at the end stage, who are terminally ill, they do not respond to antidepressants. So this is the outlook of the caregivers. Some are started on antidepressants only in the last few weeks of their life. So they are nearing the death. Only then they are starting with antidepressants when there is insufficient time for medication to have any therapeutic effect. So at that point of time, when there are only a few weeks of time for the patient, and the patient is going to die, and when the antidepressants are started at that stage, the body is not going to respond to the antidepressant, because for any medication we need a time period for responding to the medication. And if it is given almost at the end of their journey, then they are not going to respond to the treatment like the antidepressants. Antidepressants are the drugs that are given to the patients to overcome that depression, that psychological condition. Let us see about the diagnostic criteria for depression. The American Psychiatric Association's Diagnostic and Statistical Manual for Assessment of Mental Retardation says that diagnosis of depression in physically healthy individual requires at least two types of symptoms. They are calling it as two core symptoms. So the DSM-4 criteria of the American Psychiatric Association says that in order to find that a person is depressed, there are two core symptoms that has to be identified in the person. So those symptoms are, one is the depressed mood. So their mood is depressed. They are always low. The mood depression is found in the patients. Next is anhedonia. Anhedonia means lack of interest, diminished interest on themselves, on their family, on their surroundings, or pleasure in activities. So they don't get any kind of pleasure in doing some activities. Say for example, we are reading a book. Reading is a pleasure, or watching a TV show, that is also a pleasure. But these people, they do not show any kind of pleasure, or they do not show any kind of interest in the environment around them. So these two are the core symptoms for the identification of depression in the patients, and they should have at least four other symptoms. So we have a list of symptoms. We will see them one by one. Weight change in the patients. So this weight change is usually unintentional. It can be either in the form of weight gain, or it can be in the form of weight loss. So the person is found to be depressed. So they don't show any interest in eating as well, but in spite of that, if there is excessive weight gain or excessive weight loss, that is more than 5% of their body weight in a month, then that is used as a tool or a criteria for the diagnosis of depression. Next is sleep disturbance. So their sleep pattern changes, the sleep cycle changes. There may be insomnia. Insomnia means lack of sleep. They don't sleep well, or restless sleep, or hypersomnia, which means they keep on sleeping all the time. So both are two extremes. They don't sleep is insomnia, or they oversleep, that is hypersomnia. So this again could be an indicator of depression. Psychomotor problems like agitation or retardation. So agitation is overreacting to things, or not at all reacting to things or issues that happens. Lack of energy, they feel they are extremely tired, or they don't have energy to do anything. So these all could be a symptom of depression. Excessive guilt, feelings of worthlessness or inappropriate guilt. Guilt is when something bad happens, or when a mishappening occurs in the family. Maybe it can be a loss, or it can be an accident, or anything can happen. So they take the guilt on themselves. They blame themselves. So that is called as the inappropriate guilt, or worthlessness. Worthlessness means they think nobody takes care of them, nobody respects them. So such kind of feeling is worthlessness. And poor concentration, diminished ability to think. They're not able to think about an issue, about what's happening in the family, or what's happening to them, or concentrate. Right, when somebody will keep on talking to them, but they will have their concentration elsewhere. They will not listen to what another person talks to them. And indecisiveness, so they're not able to decide on things. Suicidal ideation, so this is a very bad criteria. Suicidal ideation, recurrent thoughts of death or suicide, they want to die. Or some will have a feeling of committing suicide, or they attempt suicide also sometimes. So these all could be certain indicators or diagnostic criteria for depression. If they have the core symptoms, and along with the core symptoms, if they have any of these, then that person may be depressed. Each symptom which we have discussed now may be severe. It should be severe, that is, most of the day they should be in that state of mind, or their behavior should be related to the diagnostic criteria, or every day they should have it. Durable, it should be for a period of more than 2 weeks. So sometimes one day we feel depressed, then the next day we come back to normal, and we take a high, then that's not a diagnostic criteria. It should be durable. So if it is there persistent in the patient for more than 2 weeks, and be judged to cause clinically significant distress or impairment. So, if this depression is going to cause distress in the patient, or if it is going to impair their normal activities, then again it is a diagnostic criteria for depression, not be attributable to the patient's medical condition or therapy. So, the depression that exists in the patient should not be because of the medical condition, that is the illness of the patient, or it should not be as a side effect of the medicines, the therapy that are given to the patients. In palliative care, the significance of somatic symptoms is questionable, as all may be attributable to the disease or treatment. The somatic symptoms are the symptoms, the pain that takes place or the disability that takes place in the person. So they are all questionable, and it may be due to the progression of the disease, or some also can happen due to the treatment that is taken for that particular disease. They might be considered significant if they are clearly out of proportion to the physical illness. Sometimes the disability that is present in the person may be abnormal. It may not be a part of their disease. But when they say, when we find that people become disabled to a great extent, uh, or if it is not proportionate to the disease progression, then that also could be because of depression. Others have advocated other criteria as indicators of depression in terminally ill patients. And what are those indicators? The indicators of depression in the terminally ill patients, they are divided into various categories. The psychological symptoms may be dysphoria. Dysphoria means anxiety, dissatisfaction of how they are. And there could be depressed mood, sadness, tearfulness, crying all the time, lack of pleasure, like they don't enjoy anything, hopelessness, they don't எதுலயும் ஒரு பிடிமானம் இல்லை, they don't have any hope on individuals or hope on things. Helplessness, they feel that they are out of help, that nobody can save them. And worthlessness, so worthlessness is they don't value themselves, they don't value what they have, or they don't value their qualities or their possession, anything. And social withdrawal, slowly they don't interact with the society, and then with their relatives, then with their family members. So that is social withdrawal. And guilt, so taking or blaming themselves for all the mishappenings that are happening in the family. And the suicidal ideation, so the thought of suicide occurs recurrently in these individuals. So these are some of the psychological symptoms that are indicators of depression in the terminally ill patients. The other indicators include intractable pain or other symptoms. Intractable pain or other symptoms. Intractable pain is the pain which cannot be controlled by a medical treatment. So, this is something psychological. So, it cannot be treated with the medicines. And excessive somatic preoccupation, which means they always complain about the pain and the severity of the pain. So, somatic is the body, so excessive somatic preoccupation. And disproportionate disability. Disproportionate disability. So the disability that occurs for a particular illness will depend upon the degree of progression of the disease. So in the patients who are depressed, the disability is more. Even if the disease progresses less, the disability is more in such patients. So that is disproportionate disability. Poor cooperation, they don't cooperate, even for the medical treatment they don't cooperate, or for the procedures that are involved in the treatment, or refusal of treatment. Some of them, they just refuse treatment. Some of them, they don't take medicines, they don't cooperate, they don't take food. So such may be present in certain patients. And history related indicators are the history of depression. If they have already had depression when they were a normal individual, or if they have had a history of alcoholism, if they are prone to consume alcohol or substance abuse, if they have had the habit of taking drugs, or pancreatic cancer can also cause some or these are some disorders that are associated with depression in the terminally ill patients. Let us see the clinical spectrum of depression. There are different types. First type is the normal depressive symptom. Symptoms of depression and anxiety that occur as part of a normal psychological stress response at times of crisis. So all of us feel depressed at some point of time. And when do we feel depressed? When something does not happen as per our expectation, we feel depressed. When you don't have expectation, you will not be depressed. So our expectations may be very high, and sometimes we may not reach that, and this causes a depression in the individual. And in case and when there is a crisis can be of any type, so financial crisis or anything, so that also can cause depression in the individual. Last 1 to 2 weeks, so it has to be for a period of 1 to 2 weeks. So for about 15 days, if a person is continuously depressed, then that comes under the normal depressive symptom. We may be depressed maybe for 5 minutes, 10 minutes, 1 hour. Maybe in the forenoon we are depressed and in the afternoon we become okay. Or one day we are depressed and the next day we become okay. Then that is not indicator of depression. If the person is constantly depressed for a period of about 2 weeks, then we call it as the normal depressive symptom, and resolve spontaneously with time and appropriate supportive care. And this type of depression will resolve. It will come back to normal as the passage of time. Maybe the person is depressed because of loss of spouse, or because of loss of their children, or because of the loss of their property, or it can be an accident, right? So anything, any crisis that occurs in the family or in the relations, so it does cause depression in the individuals. But after the passage of time, the person comes back to normal, so it will resolve spontaneously with time and with appropriate supportive care. And they also require some kind of supportive care, like counseling may be required, and some people may also require some medical therapy may be required for some persons as a supportive treatment. So this category, they are called as the no or they suffer from the normal depressive symptoms. The next one is called as the reactive depression, adjustment disorder with depressed mood. So reactive depression, adjustment disorder with depressed mood. So this differs from the normal stress response, right? This is not a normal stress response. So the earlier one which we saw was a response to stress, but this is not a normal stress response in either degree or duration, right? So it is not because of the response to stress. It is maladaptive, right? Which means it is abnormal. It is greater than would be expected as a normal reaction. So this kind of depression is not a response to some loss or crisis, but it is higher than that, right? It is more than the normal reaction, and it lasts longer than expected, more than 2 weeks. And it may be more severe or intense, causing more disruption and interference with daily functioning. So this kind of depression, it causes disturbances in their day-to-day activities, in their daily functioning, right? So they don't do their, maybe if she is a housewife, they may not be able to do their household work, or they don't take care of themselves, so they're not able to do even the daily functioning, social activities. Social activities, how they interact with the society, their neighbors, their friends, and relationship with others. So the kind of relationship which they create, or which exists between the others. So everything is disturbed. There is disturbances in the relationships. There are disturbances in the social activities, and also there are disturbances in their day-to-day activities. The next type of the depressive disorder is the major depressive disorder. Symptoms are usually more severe. So, compared to the other two types of disorders which we discussed earlier, here the symptoms are more severe. The mood is incongruent with the disease outlook. So, there is incongruent is it does not matches the disease. The mood swings, it does not match, or it is not related to the disease. It does not respond to support. This kind of depressive disorder, it does not respond to the supporting mechanism like counseling that are given to the patients, understanding, caring, or distraction. So they don't respond to the support mechanism. And even if there is somebody, a very understanding person who takes care of them, they don't respond to that, or they don't comprehend that. They don't actually realize all those things. And also they don't realize that they are taken care of well. And also they don't respond to distraction. Already we have seen about distraction is we distract the patient with maybe the news, the issues that are going on. We try to shift the focus from their disease, from their pain, to something else. So that is the distraction. So they don't respond to all these, and correlates with the desire for death in the palliative care population. So, a patient with major depressive disorder is obsessed with the desire of death. They want to die. And the next category is the organic brain syndromes. Patients with acute confusion, which is called as delirium, or early dementia. Dementia is loss of memory, may exhibit features of depression. So here the patients are confused. They don't know where they are, how they are, who they are, and where their home is. Some of them even forget their address, their name, what they were earlier, everything they forget. So, and dementia, they forget everything, and they exhibit features of depression. The examination will reveal evidence of organic brain dysfunction. In these patients, there may be some abnormalities in the brain and the function of the brain. Delusional thoughts. Delusional thoughts is and hallucinations. Delusional thoughts is something is not there, but they think that that is there. And they may be talking all alone, thinking that somebody is with them. They think that somebody is with them, talking to them, but actually they are not there. So that is called as delusion. And hallucination. Hallucination is something which does not exist. They think that it is there with them, or they have been to that place, or somebody is near them, somebody is frightening them. So hallucinations and features of psychotic depression may. How do we assess these patients? The structured clinical interview is the gold standard for the diagnosis of depression. So they have a structured clinical interview, which is like a schedule, a questionnaire, where there are a set of questions. By asking that questions, or by observing the patient and marking in the questionnaire, we will be able to understand whether the patient has depression or not. So you have to use an interview, talk to the patient, or talk to the caregivers of the patient. If the patient is not in a position to talk, you can talk to the caregivers and find out from them what are all the different problems that are faced. The use of a single question, are you depressed, correctly identified the eventual diagnostic outcome in a series of 197 palliative care patients. So, what does this mean? Nobody had asked them that question. If the doctor or if the caregiver had asked the patient, are you feeling depressed? The patient would have told yes, only if they are really depressed. If they don't feel depressed, they are going to say no. And this was studied in about 197 palliative care patients. Physicians unfamiliar with palliative care, they don't ask this question, feeling that the patient would always say yes. Not necessary. Not all the patients would say yes. There would be patients who know about their physical conditions, who know what will happen when their disease condition becomes worse, and what will be the reactions of the family members. They understand certain patients to a certain extent. They can they will be able to accept whatever has come to them. Many patients do not accept, but there are some patients who can accept, and such patients, they don't feel depressed. So the you should always not think that all the patients who are terminally ill should be depressed. The treatment for the patients with depression. So you have to first identify, that is diagnose and treat organic brain syndrome if it is present. If there is any if there is any problem in the brain, then that has to be treated. Exclude adverse effects of drugs and drug interaction. So if that depression is due to drugs, yes, some drugs do cause depression. If there are certain drugs that cause depression, identify those drugs and try to remove those drugs from the medication. And also you have to have a look into the drug interactions. So for the treatment of a particular disease, we do not give a single drug, but we give different types of drugs. So that drug interaction can also cause some problems, and it can lead to depression in the individual, particularly those associated with opioids, steroids, and benzodiazepines. So these are some drugs that can cause depression in the individuals. So they should be identified, and if it is not required for the treatment, they may be removed from the treatment schedule. Treat any causative or aggravating factors. So first you find what is the cause of depression. So the cause of depression may be pain in the individual, or it can be other physical symptoms, it can be social, cultural, or spiritual. So you identify what actually causes the depression in the individual, whether it is the physical pain, or it is because of the family or the society, or it is because of the culture or the spiritual issues. You identify them and you try to remove them. General support. This is extremely important for the patients who are terminally ill and those who are particularly depressed. They should be taken care of and they should be empathized. So there should be some individual, or there should be the entire family who should take care of the individual who is terminally ill, and you have to empathize with them. Empathy is respecting what they feel, and reassurance of continued care and interest. So this is very important. They should be given assurance that they will be taken care of till they are till their end, till they are alive, which many palliative care patients fear they may lose. So many of the patients may feel that as long as they are in the hospital, they'll be taken care of by the medical team and the other paramedical staff, and also by their family members, of course. But once they go home, they may have a fear that they may be not taken care of by the family properly. Provision of any information about the illness requested by the patient. If the patient wants to know something about himself or herself, or if they want to know about the treatment modalities that are given to the patient, if they are keen about that, if they are interested in that, so that particular information should be given to the patient. There is nothing to hide, because the patient themselves, they want to know about the treatment protocol. So you can tell the patient about what kind of treatment they'll be undergoing for that particular disease. Explore patients' understanding and fears about illness and their prognosis. So you should also try to know whether the patient has understood what the disease is and what will happen when the disease progresses, and the fears about their illness, and also the prognosis. Prognosis is the future or the forecast about the disease. So you should try to understand all these things about the patient's mentality and what they think about the disease. Encourage them, strengthen the family, and also try to give social support. So you should encourage the patient, give them encouragement. So as long as they live, they should lead a very dignified life. So give them encouragement. strengthen the family. So some of them, the entire family may be shattered if there is a disease, maybe in the mother or the father of that family. So you should strengthen the family, and also the social support should be given to the patient. Many patients worry more about the relatives than about themselves. They don't even bother much about themselves, but they are worried about who will tell what they would say, what they will think, and who will blame them. So they are more worried about the others, about their family members, about the relatives, rather than themselves. Brief supportive psychotherapy may also be needed for the patient's resolution of issues regarding the disease, treatment, their future, and the coping mechanism. So they can be given some kind of psychotherapy. They can be given counseling sessions in order to make them accept the disease and know what the disease is and know what the treatment is and how they should cope up, right? So all these can be dealt with by psychotherapy. And the family also should be given therapy, right? Family also should be given counseling. It is not enough only if the patient receives counseling. The entire family should be given counseling. And group therapy also may be helpful. Group therapy is the individuals of the same kind of disease, same nature of disease, they can be given therapy as a group, because they know that everybody is similar to them, and they have a kind of understanding. They will know that there are other people like them who are also suffering, who also have some pain, who also have such problems. So group therapy also will be helpful for them, and particularly useful for a dysfunctional therapy. So the psychotherapy is usually given when the other kinds of therapy are not useful to them, or if the patient does not respond to the other kind of therapies, then they can be given supportive psychotherapy. And also behavioral techniques to change their behavior, to change their attitude, to change their perspective on an issue. So they can be given behavioral treatment therapy, or behavioral techniques can be taught to the patients. And next comes the antidepressants. Antidepressants are the medicines, the drugs that are given to relieve the patient from the depression. Other drugs such as hypnotics, anxiolytics, and neuroleptics can also be given in the patients who are depressed. Antidepressants are classified by their action or by their activity, and they are grouped into different types. SNRIs, which are serotonin and noradrenaline reuptake inhibitors. SSRIs, which are selective serotonin reuptake inhibitors. NRIs, noradrenaline reuptake inhibitors. Don't worry about all these. These are all the medicines. So we have nothing to do with these medicines. The doctor or the physician will take care of this. We just have to know what they are. NASSA, noradrenergic and specific serotoninergic antidepressant. Serotonin 5-HT2 receptor antagonists, monoamine oxidase inhibitors, psychostimulants. Methylphenidate has been used for patients with advanced disease, and certain herbs such as the St. John's wort can also be given, which is an extract that is obtained from the tree called as the St. John's wort, and the botanical name is Hypericum perforatum. So in this segment, we saw what depression is. We saw the diagnostic procedures, the clinical spectrum, the treatment modalities that are available for treating depression in the patients who are terminally ill. Thank you.